Good afternoon, everyone. Welcome to yet another edition of Continual Educational Webinar Series conducted by Vijaya Diagnostic Center. I am Dr. Hatim, Consultant Biochemist at Vijaya Diagnostic Center, Himayatnagar. I thank everyone for joining us today. We are presenting today maternal screening markers. And our speaker is today Dr. Deepika Yarlagadda. She is Consultant Biochemist at Vijaya Diagnostic Center. Dr. Deepika has done her MD Biochemistry from Nizam Institute of Medical Sciences, that is NIMS. And before starting the presentation, for all the audience, I would like to inform that if you have any queries or questions, please type them in the comment box so that we can take them after the presentation. So now, without any further delay, I would like to turn over to Dr. Deepika for her presentation. So, Dr. Deepika, over to you.
Thank you, sir. So now going into the webinar topic, that is maternal screening markers. So screening, it is done to identify a disease at an early stage so that if there is any risk, can go for definitive diagnostic testing. So our particular topic, it is screening of a pregnant woman. Why we have to screen pregnant women? So according to the American College of Obstetrics and Gynecology, there is occurrence of the chromosomal abnormalities in approximately 1 in 150 live births. And the most common cause of these chromosomal abnormalities, this aneuploidy, it is seen earlier in gestation and it accounts for a large early pregnancy loss. So this is a normal karyotype of a human where there are 22 pairs of autosomes and 1 pair of sex chromosome. And this maternal screening, the prenatal tests are done to assess risk of fetal aneuploidy as well as neural tube defects. And the most common fetal aneuploidy is trisomy 21. This is also known as Down syndrome, whereas in this 21st position, in addition to this pair of a chromosome, we have an extra chromosome, which is known as trisomy 21. And this is the most common chromosomal aneuploidy. And the second is the trisomy 18. And the other is trisomy 13. So the purpose of doing these screening tests is to identify those women who are at high risk for carrying an affected baby. And by identifying these women, we can go for targeted diagnostic testing like chorionic villus sampling or amniocentesis. So the chromosomal disorders, the most common thing is the trisomy 21, and the prevalence of this Down syndrome is 1 in 700 live births. And because of this presence of an extra copy of a chromosome, it will change the baby's body as well as brain development, causing both mental and physical challenges or disability for the baby. And the second most common is the trisomy 18, also known as Edwards syndrome, where the prevalence is 1 in 3,000 live births. And the next is the trisomy 13, also known as Patau syndrome, and the prevalence is 1 in 6,000. And apart from this, we have neural tube defects, where one baby is affected out of 500 infants. And the commonest form of these neural tube defects is anencephaly or spina bifida. And in anencephaly, there is failure of development of the brain as well as the skull bones which surround the brain. And the neural tube beneath the backbone fails to develop. We call it as the spina bifida. And whenever there is an open neural tube defects, the biochemical marker which leaks into this thing is the alpha fetoprotein, and it is increased in neural tube defects. This table represents the chromosomal abnormalities increase depending upon the maternal age. The chromosomal abnormalities like trisomy 21, 18, 13 or the sex chromosomal aneuploidy, anything, as the maternal age increases, the risk of carrying a fetus with a chromosomal abnormality also rises significantly. So now, what is this prenatal screening or maternal screening? It's not a single entity. It depends upon several factors. Like there will be biochemical markers like pregnancy associated plasma protein A, HCG, which may be free HCG or total HCG, alpha fetoprotein, unconjugated estriol, and inhibin A. And the next we have, depending upon the radiological findings, we can screen the pregnant women. And those are the length of the fetus from crown to rim. We call it as CRL, nuchal translucency, nasal bone, whether it is present or absent, biparietal diameter, and femoral length. And also we have risk factors like origin of the mother, weight of the mother, whether she's diabetic or not, any smoking history, whether the pregnancy is spontaneous conception or undergone any assisted reproductive techniques, any IVF, whether it is a multiple gestation, whether it is a single baby or a twin baby, or in the previous pregnancy, if there is any history of trisomy. And these markers from where they are produced. These are produced either from the placenta or the fetus. And these marker concentration varies depending upon the gestational age. They follow a particular trends. For example, if it is an alpha fetoprotein, as the gestation age increases, the levels of these alpha fetoprotein increases. Whereas for HCG, initially HCG is high. After a particular time, it follows a decreasing trend, and at a later weeks of gestation, it will be constant. So, depending upon the concentrations, based upon the gestational age, a median will be established, and it is calculated as MOMS. MOMS is multiples of median. That is, it is the ratio between patient result and the median result for that particular gestational age. This is a graph of a double marker where the biochemical parameters or radiological anything, they will be converted into MOMS. Here the PAPA and free beta HCG, they will be having a value of in milli international unit per ml, but this value has been converted to MOMS. So this screening is done in first trimester as well as in second trimester. First trimester screening, it is traditionally done at a gestational age of 11 weeks to 13 weeks to 6 days. And the biochemical markers which we do during the first trimester are PAPA as well as free beta HCG. And these markers, they help in a detection rate of up to 67%. And apart from this biochemical screening, in the first trimester, we also see the radiological findings like CRL, NT, as well as nasal bone. And the CRL, it should be in mm, and nuchal translucency in mm, which is converted to MOMS. And the nasal bone, whether it is present or absent. So whenever there is increased NT, there is increased risk for Down syndrome or other fetal disorders. So when NT alone done, there is a sensitivity of up to 68%. But when we combine this both biochemical and ultrasound screening, there will be increased sensitivity and the detection rate will be 85%. So the below is an example of a pregnancy with Down syndrome in the first trimester, where there is increased NT and the free beta HCG will be high and PAPA will be low. So the other factors which will affect the levels of the maternal serum markers irrespective of the gestational age are the weight of the mother, diabetic status, smoking. All this we have discussed in the previous slides. So the advantages of the first trimester screening is it allows for termination of an affected pregnancy at an early stage with less psychological burden, and an early result will give reassurance or assurance to the mother. Next, in the second trimester, this screening is usually done at 14 to 21 weeks of gestation. Here we have triple screen, where the markers measured here are alpha fetoprotein, unconjugated estriol, and human chorionic gonadotropin. And we have quadruple screen. In addition to the triple screen markers, we have inhibin A. And this second trimester screening is done to identify risk for neural tube defect as well as trisomy 21 or 18. So the most important marker for second trimester screening is the alpha fetoprotein. From the name itself, it is synthesized from the fetus. In the early gestation by the fetal yolk sac and in the later gestation by fetal GIT and the liver. So whenever there is a open fetal body wall defect, this AFP will be leaking into the amniotic fluid. Then it goes into the maternal circulation where we can measure the levels of the alpha fetoprotein. Here is the example of a marker profile of a pregnancy with Down syndrome in second trimester. In second trimester, the HCG will be high and the inhibin A will be high, especially for a quadruple marker. If it is a triple marker, HCG will be high and the remaining two AFP and unconjugated estriol will be low. So this is a brief of a biochemical screening done in first and second trimester, and these are the biochemical markers. The first trimester, we call it a double marker. We have PAPIA and free beta HCG, whereas in second trimester, we have a triple marker screen and quadruple marker screen. So there was a trial conducted at US for a period of 3 years, where they compared both these first trimester screening and second trimester screening. When these screening were done individually, when only first trimester or second trimester screening was done, the detection rate of these chromosomal abnormality is up to 80 to 85%. And if it is a triple screen, even the detection is lower, it is only 65 to 69%. But when they combine both these first trimester and second trimester screen, the detection rate is up to 95% for a chromosomal abnormality. And we call this combined as a full integrated screening. So the molecular techniques for these prenatal diagnosis, that is non-invasive prenatal testing. Free fetal cells in the maternal circulation, but this is a very complex technique. So the usual test done is the free nucleic acids, DNA and RNA in the maternal circulation. And according to a recent meta-analysis conducted in 2017, reported that through this technique, identification of the free nucleic acids, there is a detection rate of 98 to 99% for these chromosomal abnormalities, either it is a trisomy 21, 18 or 13. So what is the testing we follow here at VDC? So the process flow is, we have a test requisition form and we'll take informed consent from the patient. Then we will be drawing sample from the patient under aseptic conditions. That sample will be tested in our laboratory at Himayat Nagar. And once the biochemical testing was done, the entry of these biochemical data as well as the radiological findings into the software. And the software we follow here is Prisca. And then validation of the results by the consultants. So this is a test requisition form. In the first column, where we have demographic details of the patient. And next is, what are the tests to be done? If it is a first trimester screening, it's a double marker. And the ultrasound findings required are the CRL, NT as well as nasal bone. If it is a second trimester screening, the test done will be a triple marker or a quadruple marker. And the ultrasound findings needed here are the gestational age by the scan data and the biparietal diameter. And this column will be the brief clinical history or risk factors like the diabetic status of the mother, smoking, the number of fetus, any IVF status, or any previous trisomy pregnancy, and date of birth of the mother. And last column is the consent of the patient. So this testing of these biochemical markers, the method we use this chemiluminescence immunoassay, and the evaluation is done using a Prisca software version 5.2. So this is how a graph of a double marker looks like. So here we have in the first column the demographic details of the patient, name and date of birth, and the sample drawn date and the gestational age. Next, we have the risk factors like the number of fetus, weight, diabetes, IVF, or any previous trisomy. And the biochemical data, since it is a double marker, we have PAPA as well as free beta HCG. And this is the ultrasound data. And this double marker, particularly it is done in first trimester. So the first trimester scan will be having CRL, it should be in mm, and nuchal translucency, it is in mm but converted to moms, and the nasal bone, whether it is present or absent, and the gestational age. This box depicts the risk analysis, and this is the description for risk for trisomy 21, and this for trisomy 13 or 18. Next, this graph represents a double marker risk example. So here in this graph, the risk cutoff is 1 in 250. That is, if it is more than this, we consider them as high risk. See, for example, in this particular graph, the age risk is 1 in 314. That means out of 314 pregnancies, one pregnancy is affected for the trisomy or a chromosomal abnormality. The second column is the biochemical trisomy 21 risk. So after doing these biochemical markers, the risk is 1 in 3064. So out of 3064 pregnancies, one pregnancy will be affected for this trisomy 21. And the third column is the combined trisomy 21 risk. That is, along with biochemical markers, we take into consideration of the radiological findings. And the risk is more than 1 in 50. That is the risk of for trisomy. So after calculation, it is expected that among 50 pregnancies with the same data, there is one trisomy 21. Then this is a graph of a triple marker. The first column is the demographic details, then biochemical markers. Here, since it is a triple marker, we have AFP, unconjugated estriol, and HCG. And the radiological data which we will be taking is the gestational age by scan, and mostly we will be taking the biparietal diameter. If it is not available, we will be going for the scan data. Then this represents the trisomy 21 risk, this column, the description of the trisomy 21 risk, and this for risk for neural tube defects as well as trisomy 18 risk. So this is a triple marker risk example, where here this trisomy 21, the affected is 1 in 92. And this is above this cutoff. That is, among 92 pregnancies with the same data, one woman with trisomy 21 is present, and the remaining 91 are unaffected. And this first one is the risk for the neural tube defect, where the AFP is taken into consideration, where it is converted to moms, and there is a low risk. And the risk for trisomy, when calculated for trisomy 18, 1 in 57 is affected. That is, out of 57, one pregnancy is affected, which means it is an increased risk. Next, this is a marker of a quadruple screen, graph of a quadruple marker. The first column, demographic details, then biochemical markers. Here, in addition to the triple screen marker, we have inhibin A. And the radiological data, the same will be taking either the BPD or the scan data. And this column depicts the trisomy 21 risk, and this is for the neural tube defect or trisomy 18 risk. And this graph is a quadruple marker risk example. After calculation, the risk for trisomy 21 is above the cutoff, which indicates an increased risk, and the affected is 1 in 50. That is, among 50 pregnancies, there is one trisomy 21 pregnancy. And neural tube defect risk, it is a low risk. And the trisomy 18, it is 1 in 3,255, where it indicates a low risk. The take-home message is, this is just a screening test and the test is optional. A negative result will not guarantee a healthy baby. Since this is not a diagnostic test, it's just a screening test. And a positive result doesn't mean the baby has a problem, but we can do further testing like chorionic villus sampling or amniocentesis. Thank you.
Right. Thank you, Dr. Deepika. That was a very elaborate presentation. I think if we have some questions here, some queries. One of the queries: is there any change in screening procedure if it's a IVF pregnancy? What if it's a IVF pregnancy?
If it is an IVF pregnancy, we have to consider the date of birth of the donor.
Okay.
And we have to enter the date of birth of the donor instead of the mother, and we have to calculate the risk.
So risk will be calculated as per the date of birth of the donor of the egg, not the mother of the, age of the mother. Okay, right. We have one more question. Suppose if BPD value is not given in the scan, then by which determination method risk assessment is done in triple or quadruple marker?
Generally, in triple or quadruple, we'll be taking the BPD by the Hadlock method. If that data is not available, we have to take the gestational age as per the ultrasound. And we have to calculate the weeks.
Okay. So you can take either gestational age as per scan or LMP also, I think you can take. Yes. I think one more question we have, that is how maternal marker screening is done if it's a twin pregnancy. Is there any difference between a twin pregnancy or a singleton pregnancy?
So if it is a twin baby, the radiological findings will be different for the fetus 1 as well as the fetus 2. We'll be entering that data under the ultrasound screen data, and the biochemical marker will be the same for both the babies. And accordingly, we'll be calculating the risk from the software.
Okay. So the biochemical data will be the same, but two different graphs will be given for two different twin babies. The babies are alive, right? I don't think we have much questions or queries here. So by this, we come to the conclusion of this presentation. I once again thank everyone for joining us today. And I want to tell there is a recorded version of this presentation available on YouTube, Facebook, and LinkedIn. So later on you can watch. So thank you, Dr. Deepika, and thank you everyone once again. Thank you.